This is Dr. Katie Bodine, and we're going to be talking about vitamin D deficiency today. And if you're wondering why a vitamin deficiency is included in the endocrine portion, it is because vitamin D deficiency is closely related to hyperparathyroidism. Basically, vitamin D deficiency causes hypocalcemia. Okay, this in turn stimulates our production of parathyroid hormone, resulting in hyperparathyroidism. And long term, this causes some major health problems. But hyperparathyroidism increases the absorption, bone mobilization, basically releases calcium, and then renal conservation of calcium, but it also increases the excretion of phosphate. So then our serum levels of calcium may be normal, but only because of the hypophosphatemia, and then bone mineralization is impaired. So vitamin D deficiency, it's just as a general overview, it's usually acquired and it's very common worldwide. It's both a hormone and a vitamin. And again, the deficiency results in osteomalacia and rickets in children. Okay. There are some rare autosomal recessive forms. We won't be covering them here. That is not the purpose of this general overview. So causes are hypocalcemia, hyperparathyroidism, which again results in impaired bone mineralization. So this is basically a secondary form of hyperparathyroidism when we have extreme deficiencies. Prevalence is about 40% of the population. That's a big portion of our population, and risks include inadequate sun exposure and darker skin, being female, elderly, and obese, low socioeconomic status, and the rates are actually higher in Blacks and Hispanics, and people who live in the north. They're not getting as much sunlight, right? It's cold outside. Institutionalized patients, so if whether they're in a nursing home or in jail, they're not getting enough sun. Also, people who are depressed, they tend to not want to go outside much. And then medications can be a big risk for the development of this. Specifically, people who have had bypass surgery, they have malabsorption syndromes, or particularly anti-epileptic drugs inhibit the absorption of vitamin D as well. Just some pediatric considerations here. The NHANES data reports that 70% of children don't have sufficient vitamin D serum levels. Okay, so about 9% of children are deficient, and 61% are insufficient. So deficiency associated with high blood pressure. It can be associated with low HDL cholesterol, and the American of Pediatrics and Global Consensus recommend actually that all infants begin vitamin D supplementation within days of birth, specifically if they're only breastfeeding, because the concentration of vitamin D in breast milk is actually very low. So let's talk about some normal physiology of our vitamin D, just so we have a quick review. Vitamin D has two forms, okay, and it's essentially a prohormone, okay? So we have vitamin D2 and vitamin D3. Vitamin D2 is from plants, so don't worry. If you are a vegetarian, you're getting plenty of vitamin D. And vitamin D3 is usually from meats, and also from skin, sun exposure to UVB, okay? And at normal levels, our vitamin D2 and D3 are essentially inactivated, but they are hydroxylated in the liver to our major circulating form. Again, it's inactive. However, it is further hydroxylated in the kidney to become the active metabolite, which is calcitrol. So, hypocalcemia essentially stimulates our parathyroid to start secreting parathyroid hormone, which prompts an increased conversion of vitamin D from its inactive to its active form. The active form of vitamin D decreases renal calcium and phosphorus excretion. So it increases then our intestinal calcium and phosphorus absorption, and also increases our osteoclastic activity. So our net result is going to be an increase in serum calcium in all those different ways. Here's a nice little excerpt from Merck manuals. I thought it was a nice table that just explains the different ways in which vitamin D acts and its metabolites also act. Picture's worth 1,000 words. This is from Osmosis and just gives a nice summary of how our vitamin D is activated and then the effects of activated vitamin D. So again, just a summary of the pathophys of vitamin D deficiency. If we have low levels of vitamin D, whether this is dietary or insufficient sunlight, we then have limited calcium absorption. This results in an excess of parathyroid hormone release, which then stimulates our osteoclastic activity in order to normalize our serum calcium and phosphorus. But now we've got osteomalacia, right? We're digging into our bone stores, and that's not a good thing. Again, what's the etiology? Dietary deficiency. So for malabsorbing, malnourish, not eating well-balanced diets, and in particular, low socioeconomic status is at risk for this because we're not eating proper food, right? Fast food is processed, and we do have food desert for fresh food out there. Other countries, we have starving children. They're not getting enough dietary intake or sunlight. So inadequate sunlight exposure. So the people who like us to have sunlight recommend direct light to our arms and legs, or face and arms, hands 3 times per week, okay? Our dermatologists don't like this idea, okay? Other people who may have inadequate sunlight exposure might be a culture where people are confined to the home or religious covering. So if you're outside and fully covered, you're not going to receive that adequate sunlight. Again, institutionalized or hospitalized patients and people who are depressed don't tend to go out and get enough sunlight. People with chronic illness, liver and kidney disease, are going to have inadequate vitamin D because they are not able to hydroxylate and make vitamin D into its active form, right? And then medications, again, in cold climate. As far as signs and symptoms go, these are going to be consistent with the effects of bone breakdown, osteomalacia, right? So muscle aches, muscle weakness, bone pain at any age. In infants, they may have craniotabes, as a soft skull. It actually, palpating it might cause indentations. Yuck, right? Older infants will have delayed sitting and crawling, and then in our early years, they're going to end up having that enlarged epiphyseal cartilage, so that distal radial ulna, enlarged cartilage, the tib fib, kind of that kyphoscoliosis, hunched look, and delayed walking. Older children and adolescents will have pain when they walk. They're going to have those that bow-legged, knock-kneed look. And then in severe forms, you are going to have severe hypocalcemia. Tetany can result, and that can occur at any age. And they may have a predisposition to fractures because of the osteomalacia, right? Some of the classic physical exam signs are actually not directly due to vitamin D deficiency, but due to the hypocalcemia, which is that Chos-Veck-Stein, which is the contraction of the facial muscles when you tap along that facial nerve. You get that, it's a contraction, a spasm. And then the Trousseau phenomenon. So you're taking their blood pressure cuff, and the hand starts to spasm because of the hyperexcitability of those arm nerves. As far as diagnosis goes, history of risk factors, it's all in the history usually. So we know that senior citizens, or if you know that your patient is institutionalized, or if you know that they have renal disease, or that they've had a gastric bypass, if they're an immigrant from a colder climate or even a tropical climate where people stay inside because it's just too hot most of the year. Homebound patients, perimenopausal women, people who are veiled or dark-skinned as well. Good old-fashioned exam will be done, looking for signs. And then plain x-rays can be done in children with rickets. They'll have those characteristic deformities of the radius and ulna, and it's a very low level of radiation exposure. Adults generally will have signs of demineralization around the spine and pelvis, and we see these in DEXA scans as well. And then as far as labs go, we can just draw the vitamin D2 and 3 levels. So this is the most sensitive measure of vitamin D, and our level of deficiency is usually less than 20. We consider that deficient. You might also see an elevated ALK phos. This is from the bone-derived ALK phos. It's a marker of demineralization because it's related to osteoclastic activity, and you will see that in advanced disease and people who are bedbound coming in from nursing homes, okay? Just because their ALK phos is elevated when you're doing those screening labs, when they're coming in for altered mental status, whatnot, that doesn't automatically mean they have a gallbladder issue, right? Especially with a normal bilirubin. This is probably elevated chronically due to their bedbound state. So consider an osteoporosis screen in females that are older than 65, postmenopausal, without risk factors, or under 60 years old with risk factors. This includes low weight and tobacco use, and we'll talk about that more in our osteoporosis lecture. Okay, as far as treatment goes for deficiency, there is not a general consensus, the optimal level, okay, of vitamin D. I looked at multiple resources, and there was several different recommendations on not only supplementation but optimal levels of vitamin D in the serum. So just putting that out there, and I went ahead and went with UpToDate as it's probably the best resource and had the most evidence-based resources in coming to its conclusion. So as far as supplements are concerned, oral vitamin D3 all around is the best. It's the preferred supplement, and it's kind of cool. It actually is curative in adults with osteomalacia, children with uncomplicated rickets. So you kind of start with a higher replacement and then you taper that off. But by week 3, you can actually see improvements and see the calcium and phos deposits on the x-ray. You see the bones get better by week 3. It's pretty cool. In people that present with tetany, it's because of severe calcium and vitamin D deficiency. They're going to be probably admitted to the ICU with IV replacement. And as far as calcium intake goes and supplementation, there's actually a Cochrane systematic review reviewing vitamin D supplementation, and it's found to be very safe in healthy adults without risk of toxicity. And there may be an association with an all-cause mortality rate in higher levels regarding MI and all-cause mortality risk. However, there's also discussion regarding dietary intake of calcium, and higher doses does not decrease the risk of your osteoporotic fractures. And of course, dietary calcium has been shown to be more beneficial than supplementation. And then there is some controversy over supplementary calcium in association with increased MI, especially in women. Again, this is controversial. But we do know that supplementation of both vitamin D and calcium may potentially increase the risk of renal stone formation. Okay, so just keep that in mind if you have stone makers. So we're going to be treating our patients depending on the severity of deficiency. So again, controversial, but the National Academy of Medicine supports the level of vitamin D concentrations to be above 20 nanograms per ml. And that's based on evidence related to bone health. Now, other experts, such as the National Osteoporosis Foundation and the International Osteoporosis Foundation, as well as the American Geriatric Society, suggest that a minimum level is of 30 nanograms per ml is necessary for older adults, because this will minimize the risk of falls and fracture. However, the systematic review by the National Academy of Medicine concluded there's insufficient data to determine the safe upper limit of serum vitamin D. And there were some concerns about super elevated levels. Okay, so we'll just define the severity based on the NAM definition. So we'll define vitamin D sufficient but at risk if your concentrations are at around 20. Okay, so start supplementations if they're at 20. Vitamin D insufficiency is considered 12 to 20, and then deficiency is going to be at a level less than 12. And so that's going to be a lot more of supplementation here. Just included some fun facts for you, but when we talk about dietary supplementation is best always, cod liver oil is the most potent source of vitamin D and has 1,300 international units of vitamin D per tablet or tablespoon, if you can stomach that, okay? Great dietary sources include fortified milk and fatty fish, tuna and salmon. These are very popular in our household, and there are various studies that have shown that sufficient vitamin D levels correlate with lower levels of some cancers, and that supplements really can lower cancer all-cause mortality proper vitamin D levels lower MI risk and cardiovascular mortality at higher levels, like we discussed earlier. And you can read the rest, but lower dementia risk, improves depression. I think a lot of this has to do with sunlight, but lower pain scores. Lots of interesting benefits for having a normal vitamin D level here. This concludes our talk, and references are included here, and pictures are from Osmosis. I love my pictures. Have a great day.